Hi, everyone. So today we are going to talk about an important step in systematic review that's called meta-aggregation. There are different methods of performing qualitative synthesis of data in systematic reviews. One of the methods is called meta-aggregation. It consists of two main parts. One is called findings, and the other one is called subheadings. All right. And these subheadings are nothing but the subheadings that we will be using in our manuscript in the discussion part. All right. Okay. So I have taken this one paper. This is a systematic review on assessing the effectiveness of medication event reminder box in tuberculosis patients. So basically, we want to check the adherence of TB patients using MERM. MERM is, again, medication event reminder box. We also want to check the acceptance of MERM. What are the advantages, disadvantages, and what are the influences of demographic variables, speed, age, gender, location of like where they are staying, urban, rural areas, all of that, and influence of these factors on the adherence of TB patients to MERM. So this is one such paper that it is a trial that we selected, and I have opened the full text article. So when I want to start collecting findings, I've just zoomed in. I directly go to the results section. Introduction and methods, we don't need to read right now. We have already gone through it during risk of bias analysis and data collection for our data tables. Right now, we don't need to go through them. Right now, we need to focus on results and discussion part. But first, let's only read the results part because I don't want anybody to get overwhelmed by a large amount of text. So results is a small part of a manuscript and it's easier to go through. So there you go. This is baseline information. We are going to go line by line throughout the text under results. So from this state to this state, these many patients, these many TB patients were notified, these many were excluded. So this is basically telling us how the patients were included, how many were excluded. We don't need this information to be put in findings. So we'll move forward. So in total, there were 231 patients with age so and so, gender so and so, occupation, workers, residents, all of this. This is also, again, baseline information. If the aim of my study was to find the prevalence of farming occupation in TB patients, then this information would have been very, very important for me, right? And I would have entered this information. For example, one of our studies is to check the prevalence of TB iris in HIV patients. So or the prevalence of post-pancreatitis diabetes mellitus. So if we are looking for prevalence, then the baseline information becomes important. But in this study, we are looking at the outcome, the adherence, right, of patients. So we don't want to put this in our findings. Moving on. There you go. Acceptability of electronic medication monitor box. Before we move further, I want to give you a reading about what I have written. I've already gone through the results section and written this information. So first subheading, I have merged subheadings and findings together. I kept subheadings in bold, so it's easier for me to read. So first subheading I found was patient acceptance for EMM. EMM is electronic medication monitor. So 11% participants refused to use EMM at the beginning, while 8.2 participants refused to use it after using it for a median of so many days. Patients diagnosed bacteriologically were significantly more likely to refuse EMM than clinically diagnosed TB patients. This one will come under method of TB diagnosis. So this one is a different subheading that I just added, 4, 5. So it will be 6th point, right? So every small information that we get, I will tell you how I added all this information. First, we just want to read what all information I've added. One is patient acceptance. One is method of TB diagnosis. The influence of TB, the influence of the method of TB diagnosis on the acceptance of patients towards EMM, right? So this study might have found that patients who were diagnosed bacteriologically were more likely to refuse EMM. Then there is treatment outcome. 9% participants were stopped from using EMM because of loss to follow-up, inpatient treatment needs, that's admitted to hospital, moving to another city, or death, that's basically outcome. It can be treatment failure, transfer to DOT. DOT is directly observed therapy for tuberculosis. So the idea is from methodology of this study, we read that if a patient missed certain amount of drugs under EMM, then there is, because of poor adherence, these patients will be shifted to DOT. So 8.9 participants on EMM were transferred to DOT due to poor adherence as measured on EMM data. There you go. So we have talked about acceptance. We have talked about the influence of method of TB diagnosis on acceptance. We've talked about treatment outcome. We've talked about transfer to DOT. Now we'll talk about adherence. The average percentage of doses taken by patients was 99%. That's it. Let's see what the paper has mentioned in the results section. But before that, let's read the last subheading. Influence of occupation on adherence. And this one is influence of method of TB diagnosis on acceptance. So occupation, farmers and migrant workers were significantly less likely to switch to DOT on account of poor adherence as compared to people from other professions. So we can rephrase this sentence, but let's come to it after looking at it. All right, so we have gone through all the 6 subheadings and what has been written under them. And we'll start reading the results section of this paper. Acceptability of EMM. Out of so many people, 11.3% refused to use initially. 8.2 subsequently refused to use EMM. And their median number of days using EMM was 109. This is exactly what is written here. 11% participants refused. So what I did was I read this sentence, both these sentences. I analyzed them and rewrote them in my own words. This is very important. I did not just copy paste these 2 sentences in the table and changed 1 or 2 words or made it from active voice to passive voice. I did not do that. So that is important to know. Now coming to the next sentence. A total of so many patients consented to using EMM. That's fine. We've already mentioned how many patients did not refuse to use, so that's fine. Among these, so many were later withdrawn because of inpatient. There you go. Inpatient needs, death, departure from city, loss to follow-up. So 9.1% was under treatment outcome. We have written 9.1% stopped from using EMM because of so many reasons, right? So that can be the treatment outcome. We can also rephrase it as loss to follow-up because they were not able to use EMM. All right, coming to the next sentence. Eventually, so many patients remained patients who were diagnosed bacteriologically confirmed TB were much more likely to refuse the use of EMM. There you go. So that is the influence of method of TB diagnosis on acceptance. That's how we got our another subheading. Coming to the other part, results of differential patient management. Among so many patients using EMM, these many switched to DOT because of poor adherence. Median number of days of using EMM was this much. So it's okay if you don't add every single detail, but the general idea must be conveyed in your findings. Among so many patients who used EMM throughout the treatment course, the median adherence rate was this much. 100% adherence among so many patients. So see, this information is very difficult to interpret, right? So instead of this adherence, so many numbers that they have mentioned, what I have mentioned in adherence is the average percentage of doses taken by patients was 99.3%. I got this from here. All right. Average percentage of doses taken. It's okay if you don't write the results in such a convoluted manner. You have to read the entire thing and understand and write what is most important to convey the meaning. All right, coming to the next sentence. Compared to farmers or migrant workers, people in other occupations were more likely to switch to dot due to poor adherence. See, so basically what the sentence means is farmers and migrant workers have better adherence. So that's what I'll be writing. I'll be rewriting this sentence. It's not uh, exactly conveying the meaning. So farmers and migrant workers showed better adherence to EMM or to TB treatment on EMM as compared to people from other occupations and they were significantly less likely to switch to dot of poor adherence. Questions. So the first idea that the sentence should share or give us is that farmers and migrant workers have better adherence. And that's why I rephrase this sentence. I might rephrase the sentence still because this is a very long sentence and we need very short sentences and to the point sentences. And more importantly, the sentence should convey the meaning right at the beginning. So farmers and migrant workers showed better adherence to TB treatment on EMM as compared to people from other professions. So I can put a full stop here and say they were significantly less likely to switch to dot on account of poor adherence, right? So I'm now happy with these two sentences and I have conveyed this meaning as well. Remember, I did not mention the OR. I think it's odds ratio. I have not checked the full form. I have not mentioned the confidence interval, nothing. Just convey the idea. Also migrants, because if we are going to use odds ratio and confidence interval, then we need to analyze this information from all papers that we have selected and do that using meta-analysis formulae. But we are doing a qualitative synthesis, not a quantitative synthesis. We can still mention percentages, all right? That still comes under qualitative synthesis, but we're not going to focus on the biostat stuff. Okay, moving forward. Also, migrants more often demonstrated poor adherence and switched to dot than did patients who came from the local county. This is also a very, very important point. So this will come under influence of, I would say, location, residence on adherence, right? So migrants were more likely to miss doses, drug doses, and be transferred to dot as compared to the locals. You see how I changed that sentence? The meaning should be conveyed. So this is another subheading, as you saw, influence of residence on adherence. Coming to the next sentence. Retreated TB patients were more likely than new TB patients to switch to dot due to poor adherence. The reason why I am not adding all this information in just one sentence, I could have very easily done migrants and retreated TB patients were more likely to miss drugs, while farmers and migrant workers were less likely to miss drug doses. But I did not do that because this sentence will fall under a different paragraph, will fall in a different paragraph. And all the papers that talk about occupation, that talk about the influence of occupation on adherence, they will be written together in one paragraph, right? I am not able to find the study I was working on. Just 1 minute. Yeah, there you go. Now I'll be clubbing all information, all findings that talk about the influence of residents on adherence together in one paragraph and then mention it together. So that is why I'm writing in different sentences and not just one. Influence of, what should I say? New or old TB case, right? So I can copy paste this sentence, and because this one I have made on my own. So I would say retreated TB patients were more likely to miss drug doses and be transferred to dot as compared to newly diagnosed cases, right? I will put this in bold so that I remember. It's easy for me to understand that this is a subheading and this is the the not bold part is fine. Moving on to the next sentence. Acceptability of EMM by healthcare workers. Now, this is an important point. In my systematic review, we are only looking for the acceptance of EMM by patients, the adherence by patients, and all of these things for patients only. We don't want information about healthcare workers. So I'm going to completely skip this paragraph, and there comes discussion. So we're not going to talk about discussion right now. We will only focus on results. So this much is what we need to do first. And I want to show the end result to you as well. Just one moment. So as you can see, this Google document contains the manuscript that we are preparing for this study, systematic review on medication event reminder box in TB patients. We are done with the introduction, methodology, all of this. Results section, these are the study tables. So this information that you see right now here, that will be created into these study tables. Good to look at and clean. This is another study table. And this is the second to last study table, I believe. This is another one, right? So there are 4 study tables, and this is the risk of bias. So whatever risk of bias we do, the end goal is to create figures like these. And then I'll be summarizing these figures later on. And then coming to discussion part. So whatever we write here under findings, subheadings, that will go under discussion. And let's focus on only the study that we worked on. There you go, this one. Yeah. So patient acceptance, influence of this, treatment outcome, transfer to dot, adherence, influence of this, influence of this, influence of this, right? So let's go. And of course, there are other studies as well. So this study, it's another study, talks about adherence, it talks about HIV load, it talks about disability, talks about acceptance, it talks about it talks about treatment outcome, all of that. Okay, so but we are only going to focus on this one anyway. So here are the discussion headings. Now, the first 2 to 3 headings under discussion, they will introduce the topic of our review, right? that information won't come from findings. So the first heading for our discussion is current trends in management of drug-sensitive TB patients worldwide. Okay. Second heading is development of digital adherence technology for TB management worldwide. It's still introducing our review subject, talking about MERM box, mechanism of action, history, all of that. And now coming to our findings. So first heading I was able to create was accuracy of MERM for measuring adherence. So the paper that we read did not give any information about this, but there were two papers, I would say. Two papers, one was this one and one was this one, which gave information, but we won't go into detail. Coming to effect of MERM on patient adherence. So let's also find. So basically, how much adherence was there? In our paper, let's see who the author is in our paper. Wang, 2019. So our paper will read Wang 2019. I'll just go through it then. There you go. So about adherence, this is another author, Wang 2019, right? So what I've done is I've just copy pasted my finding over here. The average percentage of doses taken by patients was this much percent. There you go. Adherence, the average percentage of. As you see, I've just copy pasted from these findings, but only the adherence part. And these are findings, similar findings from other papers that I have mentioned. There you go. Now switched to intensive management. In our study, they were shifted to DOT. So that will fall under this one, this subheading. Patients switch to DOT management. There you go. Wang 2019, that's our study. 8.9% patients on EMM were transferred. There you go, 8.9%. As you see, I've just copy pasted under this subheading. So there is another study, Wang 2020, which talks about patients switching to DOT. So I've added that information as well. Now, effect of MERM on treatment outcome. So Wang 2019, did it talk about treatment outcome? It did talk about treatment outcome. So let's see if I've added or not. I haven't added. Let's see the reason why I haven't added. There you go. So I have not added in treatment outcome because, well, I have, but I have not added that information under favorable outcome. I have added that information under loss to follow-up. 9.1% participants was stopped from using EMM due to whatever reason, right? So treatment outcome, 9.1% participants were stopped from using EMM from whatever reasons. So the heading or the subheading, heading is discussion, subheading is effect of MERM on treatment outcome, and subheading is favorable outcome. Another subheading is loss to follow-up. And under loss to follow-up, I've added this finding of our study. Oh, sorry, this is our study. This is another study with similar outcome. Now coming to factors influencing the effect of MERM. So first one is age. Our study did not talk about age. So I have added information from other studies, Wang 2020, Wang 2021. Influence of gender, our study did not talk about it. Influence of occupation, our study did talk about it. If you remember, farmers and migrant workers were less likely to switch DOT. So what I'll do, we did rephrase that sentence, right? So what I'll do right now is I'll just copy paste from here. There you go. And paste it here. Oops. Yeah, there's another study which says HIV positive status and unemployment was shown to reduce adherence in both arms. Now, this subheading only talks about occupation. So what I'll do is there's the influence of HIV status. Manya Zawel. Adherence to TB patients was higher for adherence to TB medication was higher for patients without HIV, employed participants, and those without any negative isoniazid urine test. So what I'll do right now is I will remove this much information. So unemployment was shown to reduce adherence in both arms. Because this only talks about occupation, I can only talk about employment here. And this only talks about HIV, so I can only talk about HIV patients. And this was higher for patients without HIV. I will remove employed participants. And what I'll do is isoniazid urine test, I am talking about it somewhere. Where did it go? There you go, isoniazid urine test. So later on, I will shift it there. Now, another thing I wanted to add was occupation, residence. So residents, we have also mentioned something, migrants and locals, right? So what I'll do is this one is here, this one is here. I'll add this information, and that is WAG 2019, right? Just reduce the size. So our paper also talks about residents, and these papers also talked about majority of participants misdiagnosis belong to these areas. RC talks about migrants versus locals. This one study talks about urban versus rural, right? Now, influence of TB diagnosis method, WANG 2019, bacteriologically were more likely to refuse EMM. That's exactly what we saw here. Influence of method of TB diagnosis, right? Now, treatment outcome we have done. Transfer to dot we have seen. Adherence we have seen. Influence of occupation we read. Residence we read. Now, only influence of new and old TB cases. So what we can do? Influence of HIV status, influence of disability. We can add another influence of old and new TB diagnosis, right? I won't focus on the subheading right now, how it sounds. When we complete this draft, we will change the grammar, the sentence structure, all of that. There you go. So this is how we write our discussion part. As you can see, in the discussion of this systematic review, we start from accuracy of MERM for measuring adherence. We go to effect of MERM on adherence. Then we go to, there you go, effect of MERM on treatment outcome, favorable outcomes, bad outcomes. Then factors influencing the effect of MERM on adherence, age, gender, occupation, residence, TB diagnosis method, old new TB cases, HIV status, all of this. Then patient's perspective on using MERM. So good points and bad points, advantages, disadvantages, acceptance. So if I've written this acceptance, then WANG 2019, you did see that 11.3% refused to use at the beginning. There you go. 11.3% refused to use at the beginning. So this is basically how we do meta-aggregation. Just giving a quick summary about the process. This is a type of qualitative synthesis. There are many different methods of performing qualitative synthesis, meta-ethnography, meta-regression, all of that. This one is called meta-aggregation, and we're going to use it for our studies. What we do is we open the full text. Let me go a bit back. We open the full text article. We go to the results section, and we start reading line by line. If our study is not talking about prevalence, we ignore most of the first paragraph. And then we want to know about acceptability of EMM. So we go through this with a fine-tooth comb. We want to know about differential patient management. We want to know, okay, that's it. Yeah, till here, we want to know about everything. But we don't want to know the acceptability of EMM among healthcare workers. So we will not go through this part. So you have to know what you are looking for. And you write all these points over here first. Why don't we write directly in the manuscript? Because we first want to create all the subheadings, right? So this is the first paper with the subheadings I got, second paper, third paper, fourth paper, fifth, sixth, and so on, right? And using these subheadings, we wrote the entire discussion. All right, thank you. If you have any questions, feel free to message me, or you can wait for the next meeting. But if your task is to conduct meta-aggregation, basically not meta-aggregation, if your task is basically to write down all the findings and with subheadings in bold for the papers allotted to you, and I suggest do this process for 2 papers, get back to me, I will review, and if you're going on the right path, then you can complete writing the findings for all your papers. And if there are some changes to be made, we will review that together, and then you can continue. This is one of the most important steps in systematic reviews, and I hope by the end of this exercise, you'll be confident with it. All right. Thank you. Bye.